Let's see. Okay, we're going to talk now about esophageal strictures that often get the patients into trouble in needing G-tubes. So we're going to talk a little bit about the symptoms and how to diagnose strictures and describe both endoscopic and non-endoscopic techniques for esophageal dilatation. Strictures are a scar that occurs in the esophagus, and the one interesting feature of epidermolysis bullosa that's different than other disorders is that these scars, strictures, are mucosal and submucosal versus being transmural or full thickness, including the muscle. So almost none of our children have transmural or very thick scars. And this makes a real difference in how you approach it. These children often have painful swallowing, and it can be a great deal of difficulty even with soft foods. Foods can lodge at the site of the strictures, they can aspirate, and many of the parents and even the patients themselves know that they're going to more soft foods and then eventually to liquid or even pureed foods. These liquids tend to pool above the strictures and can be associated with a chronic cough, fevers, and chronic aspiration. These aspiration can lead to pneumonia, which can obviously compound the nutritional issues that the child already experiences. Many of these patients have significant weight loss, dehydration, and nutritional failure and growth disturbances. Now, if you look at the different types of EB, most of the strictures occur with the recessive dystrophic type, and if you look at the different subtypes of RDEB, somewhere between 70 and 80% of all RDEB patients will eventually develop strictures in their lifetime. The other disorders such as EB simplex, very uncommon. I've seen some patients with strictures in the other subtypes and other types of EB. Junctional can be associated with strictures in a few patients. Now, the interesting thing is that why is the proximal esophagus the place where most of these strictures occur? And 60% of the patients, the only stricture is in the cervical part of really the neck portion of the esophagus. 1/3 of the patients will have 2 significant strictures, and the remainder have 3 or more strictures, and it can involve the entire length of the esophagus in some patients. The reason this is important to understand where most of the strictures are located is that when the radiologists do the barium swallows, in many institutions they're looking from the clavicles down, not from the clavicles up. And so we have had a lot of our patients come to us with severe dysphagia, inability to eat, and a reportedly normal barium swallow. And so it's really critical that the radiologist and the technologists, when they're doing the study, capture that cervical neck portion of the esophagus as the child swallows. Otherwise, they can miss the stricture. And we've had this week, we have had 2 patients that in our center that they missed the strictures because of how the study was performed. So how are these strictures treated, and what are the long-term consequences, and what are the other options when things don't work out and dilatations have limited effectiveness? So in the past, bougonnage was just sort of a blind stretching of the esophagus with a weighted dilator In rigid esophagoscopy, that's looking down the esophagus with a rigid scope with also dilators, was the traditional way of dilating these patients. Unfortunately, it traumatized the esophagus so much, and many of our patients that have been treated with this approach have ended up with the types of scars that become then resistant to dilatation. And in some cases have even required esophageal replacement with a colon conduit. So the acceptable methods today in the United States and around the world is balloon dilatation, and it can be administered in two ways. One is with a scope, a flexible scope, and the other is a fluoroscopically guided balloon dilatation, a non-endoscopic approach. There's a difference between the two types of dilatations. One, the scope itself can cause trauma to the esophagus, and the balloon size is limited to 12 millimeters in diameter. The fluoroscopically guided balloon dilatations can go up to 22 millimeters without any difficulty in certainly most of our older teenagers and adults. So the technique is very straightforward, and we put under anesthesia, we put a small, tiny tube through the mouth, past the stricture with a little guide wire, and then we put the balloon catheter over the guide wire and strategically place it at the site of the strictures. And if there's one stricture, we just put it at that site. If there are multiple strictures, we will put it at the other sites as well. So this can also be done retrograde. So we have some patients that have very small mouths, and putting an endotracheal tube in their airway is very difficult. So we can do mask ventilation, and if they have a gastrostomy tube, we can do what we call a retrograde dilatation, and really have a very effective way of managing their stricture without traumatizing their airway. And so here you see what a balloon looks like in place at the site of the stricture. It's not a very long one, it's relatively narrow, and it can be stretched relatively easily in a straightforward manner. The amount of pressure it takes to do this dilatation, and on average, is about 1 atmosphere of pressure, or up to 2 atmospheres of pressure. So not very high pressure compared to some of the other techniques that have been described. At the end of the procedure, we put a small amount of water-soluble contrast in the esophagus, just in case there is an esophageal leak or perforation. An unrecognized leak can be deadly, and we always check to make sure that there's no leak. And fortunately, in our hands, we've not had any serious leaks in over 500 dilatations. But I've heard of patients having this issue in other institutions, so we really do take it seriously. Now, this is an endoscopic picture of a patient who had a endoscopy for just after a dilatation, and I want to show you just this red area is where the stricture had been, and so this is what it looks like right after a dilatation. So the rest of the esophagus, the lining looks nice and clean and not bleeding. This would not be the case when you use a endoscope going down there. You can have a long area of trauma to the esophagus. I don't know if this is something that should be widely applied, but in our patient population, we noticed that when we gave some steroids at the time of the procedure, as well as a short course of steroids at the end for 4 or 5 days afterwards, the interval between dilatations seemed to be longer than those patients who did not get steroids. So we do give about 4 to 5 days of steroids in a decreasing dose. We always make sure the patients have a proton pump inhibitor or a H2 blocker to decrease the amount of acid, because we presume there is some reflux, although I don't think reflux causes these strictures. I think the strictures are there because of other trauma. These patients generally tolerate this very well, and most of them are, about half of them are home the same day, and those who live a long way away end up spending the night and going home the next day. But most of them are eating relatively well in a short period of time. So we've done now more than 150 such patients from 1.5 years of age. That seems to be the youngest age that strictures develop, up to 49 years of age. And the balloon size varies from 14 to 22 millimeters, depending on the size of the patient. As I mentioned, we've done more than 500 dilatations, and most of the patients have excellent relief of their patients. Every now and then we'll have a patient who complains of significant discomfort underneath the sternum. We worry about those patients. We may keep them for an extra day if necessary, but this is very uncommon. We had 2 patients who did aspirate a few years ago when they had their dental procedures at the same time. We are big fans of having multiple procedures done under one anesthetic, but sometimes dental procedures can be quite bloody in these patients, and if the airway is not well protected, they can aspirate, and this happened to these 2 children. They fortunately recovered, but I got a few gray hairs over this. And the length of time between dilatations really varies from patient to patient. We have some patients who required every 3 to 4 months, and others can go 6 or 7, 8 years. We have noticed, and this is not yet, but we've noticed that many of our older teenage patients seem to have less requirements for dilatation, which is, I think, very comforting for some of our families who are going through dilatations every 4 months, every 5 months, every 6 months, to know that at some point those children, as they become adults, may require less dilatations. And this has been verified by a number of my adult patients as well as older teenagers. So the average length of time is about a year between dilatations, but as I said, it's quite variable, and every patient is their own case study, if you will. So in our experience, and we feel very strongly about this, that fluoroscopically guided balloon dilatation is really the preferred first line of treatment for esophageal strictures. It's safe, it's repeatable, and it minimizes oropharyngeal trauma, eliminates the endoscope, it allows us to use larger balloons to manage soft strictures, and in many patients it allows us to maintain a nutritional status independent of having a G-tube. But when necessary, we do recommend the G-tubes, and their quality of life is significantly improved. And this is my princess Lexi here. Now I'm just going to spend a minute about colonic interpositions. Colonic interpositions are not frequently done in patients with epidermolysis bullosa. It is an operation that we do quite commonly for certain congenital or acquired esophageal disorders in children. When children are born without an esophagus and there's a long gap between the neck portion and the stomach, it is considered one of the techniques to be used. Or if a child has had a traumatic injury with caustic ingestion of, say, lye, not so much in the United States, but around the world, lye is still used to make soaps, and children drink this lye and can have terrible damage to their esophagus. So colonic interposition works quite nicely for those patients. In 1975, Kralik described a technique in a patient with EB, and there have been several other reports in the literature, all case reports, about successful colonic interpositions for EB. I have done this myself in a couple of patients where there have been no other options. but it's not something that we take lightly. It's technically a complex operation with significant risks, and it has, in non-EB patients, a mortality, published mortality of about 3%, and a complication rate of about 25 to 30%, including esophageal leaks, long-term strictures that have to be dilated, especially at the upper end, and other types of issues in terms of the colon grows faster than the rest of the body, so you can actually get obstruction of the colon conduit as people grow into adulthood. Now, when you look at the National EB Registry, there's about 3,286 patients in the registry. 400 of these patients are recessive dystrophic patients. 16 of these patients had a colonic interposition. Unfortunately, there's no information about how well they did. They survived their operation, we know that. And the good thing is that those that I've talked to and those patients that I've also done this operation on, if they've had a successful operation, they're really quite satisfied with the results. So it does work for patients who have this issue. And this is the data from Joe David Fine's paper in the Journal of Pediatric Gastroenterology and Nutrition in 2008 describing the patients that had recessive dystrophic EB. So less than 5% of the patients required a colonic interposition, and most of them only had one procedure, which is a good sign, which means that they didn't have life-threatening complications with the procedure. But we don't know enough about the outcomes, and I think this is certainly worth not only interrogating the EB registry, but perhaps tracking down these patients and being able to get some information about the outcomes, and so that families can make appropriate choices when faced with a decision whether to continue dilatation or not, and what kinds of options are available. So in conclusion, patients with EB and esophageal strictures, many of them have lifelong issues in maintaining adequate oral nutrition. The non-endoscopic balloon esophageal dilation technique is a very effective method in managing these strictures, and in most patients it does maintain a good nutritional status. Esophageal replacement is rarely required, but when necessary, a colon interposition is probably the best alternative that we have available. Well, using a variety of strategies, including gastrostomy, enteral nutrition can be maintain appropriate growth and lead to a good quality of life for most of our patients. Thank you very much for this opportunity. Any questions? Heidi.
Recently, I've had a dilation done back in March of last year, and the doctor had not seen me actually for the wedding. I wanted to get a dilation of my throat so I could enjoy a honeymoon. So, but then it was 7 whole years, and I think he had forgotten how delicate the operation was on me, in his opinion. So when I saw him 7 years later to have the dilation, he says, well, why haven't I seen you? And I said, well, I've been around, you know, but I'm needing it now. And he says, well, we'll just do a slight dilation, and then you can come back in about a month and we'll do another dilation. Well, I didn't hear from him after the dilation, so I finally went and saw him, and he's scared to death about doing me again. And he's scared of losing me on the table. He's fearful of, puncturing my throat and stuff. And so I had listened to you speak back when you were in California, and I remember hearing you talk about prednisone. So I had him contact you, and you gave information about the prednisone, but maybe because he didn't dilate me a second time, I'm actually needing it desperately now. And I've been listening to the G-tube talk and stuff, and I'm scared to have a G-tube. So when my throat does open up, and I think I've got other issues, and that was the question I was going to ask the pain management guy as well as you. I was on my, I had a dislocated knee about 5 years ago, and took Bextra. And didn't really help the knee, but it was awesome to my throat. And they eventually took it off the market, but while I was on the Bextra, my throat has this other issue besides the stricture. It just totally clams up, and I can't drink liquids for a lot of the day, and that's what's been happening with me now. And so I've lost about 10 pounds. So I've been trying to get this doctor to put me on something like Celebrex or something. Another doctor put me on Azizkhan, in the attempt to reduce the inflammation in my throat. But I'm kind of at a loss because this doctor is a very good doctor, but he doesn't want to lose me on the table. So do you have any suggestions? Should I come up here to have you do it, or have you give him a really good long talk and encourage him that he won't lose me?
You're welcome to come, Heidi. It's hard to answer your question just in a couple of minutes, so I'm happy to talk to you some more afterwards. But if you've gone 7 years, there's no reason for you not to be able to be dilated.
This isn't necessarily related just to the G-tubes, but I heard recently on the news about a surgical procedure that would help for reflux. Is that something that would be beneficial for an EB patient, or are we off?
Well, I do anti-reflux operations when they're indicated. So if somebody has...
My child has been on Prevacid, he's 6, since he was born. I mean, is he going to be on that the rest of his life, more than likely? These
anti-reflux operations, there are different types. And you may have heard of some of these endoscopic approaches or some newer ways. Those are untested in children. But when children have true pathological reflux that's not manageable by medications or our traditional ways of dealing with it, then an anti-reflux operation is very helpful. But if he's managed with Prevacid, I use Prevacid a lot on our patients, and they can stay on it for many years. Now, unfortunately, we don't have a 50-year track record of what the impact is of taking a proton pump inhibitor. There are some other disorders where patients have taken proton pump inhibitors for 30 or 40 years, and it's generally well tolerated, but there are some things that can happen to the stomach that may require endoscopic surveillance. And so it's another complicated question in terms of how do you manage that. For now, I think it's safe to give Prevacid. And it may be more risky to do a complicated operation. Mary.
Hello, Dr. Azizkhan.
Hello, my dear.
I know I've asked you kind of this question before, but I was just wondering again. This kind of goes along the lines of the question that Heidi had. You know, EB is very rare. It's hard to find doctors that want to work with it. can't expect that you're going to be around forever. So is there an interest with people studying with you in regards to EV that the procedures that you've come up with for dilatations are going to be passed along, that, you know, our future is safe?
Yeah, well, you ask a very important question. Yeah, I'm an educator, you know, so I may be a clinician, and I certainly love my EB family and my kids, but one of the most important responsibilities I have is to teach what I know to others, and hopefully they'll even improve on the things that I do. So I have trained dozens of young surgeons, pediatric surgeons, that have come through in the last decade, how to do these procedures well and safely, and they're starting to populate different regions of the country. I teach outside of the country. I've gone to Chile and taught our colleagues in Chile, and they are doing a fabulous job with the 200 children that they have in their population, how to manage the EB strictures. I literally teach this all over the world, and so I know I'm human. I'm not going to be around, but I need to make sure that others know how to do this well. And then if I'm out of town, there are people in the institution, Cincinnati, that can take care of you if I'm not there.
That's good. You know I've had bad experiences in the past. Yeah. You're not allowed to go for a while, at least.
I'm not planning on it.
I cannot miss the opportunity to say thank you to Dr. Richard Azizkhan. You will see in the picture on the left side is one of the patients in Chile that Dr. Azizkhan dilatated. She's 24 years old. She had severe esophageal stricture. And after 1 hour of the procedure, she's eating an ice cream. She said it was the wonderful things he made in her life. He changed the quality of life in a couple of minutes. And also to say that after Dr. Azizkhan came to Chile and trained all the team there, the team is doing the procedure for people from Argentina, for Peru, from Costa Rica, and even from Mexico, with one of the patients, the father of the patient is here. So thank you for teaching us.